How can we provide high quality and safe technology-supported care for our patients as we go home? As an emergency doctor, when I send patients home or when you send patients home from the hospital, we think we have put together a wonderful bridge so that patient can safely go home. But very often, the patients look at the bridge differently. Sometimes they may see, well, the bridge, they may be missing some steps in between, or it may be a glass bottom on the bridge. And so patients are asking for other ways that we can go home safer. And so one of my research clinical study that I'd like to just speak a little bit about, but really bring out those four levers, is a project called Tech for Home. Sending patients home with sensors and wearables, monitoring their oxygen saturation, heart rate, blood pressure, so that a remote monitoring nurse can contact the patients and work with their family doctors together to support the patient at home recovery.
When we're thinking about how to do things differently, when we're thinking about innovating, that we're not necessarily innovating the same for everybody, but that we recognize that some people may need different innovations or different intensity of innovations than others in order to achieve the same outcomes. And we've thought a lot about our approach and this difference between equality and equity. I think our approach originally when we were trying to improve screening rates was to kind of do the same thing for everyone. We would proactively reach out, for example, and recall patients who are overdue for screening, and we did that the same for everybody. But more recently we realized, maybe people who are living with a low income need a different approach. We've done some other work in our practice comparing two really high-tech methods of outreach, phone calls versus letters. And we found that phone calls were more effective at getting people to come back for screening, but that they were also more expensive. So we couldn't afford to do phone calls for everybody, but we decided we'll do phone calls for people living in a low-income neighborhood, and the others will get a letter. And so that was our first attempt at trying to take more of an equity approach in this area.
What I want to speak about is the idea of leapfrogging our marginalized populations from the emergency rooms and from the emergency shelter care to stable housing, jobs, and community primary care. We've done the Canadian guidelines for refugees. We've just finished the European migrant health guidelines, which will come out in the next probably month. And so we're now taking on the Canadian homeless health guidelines, and this is a very exciting initiative. We set priorities with 76 homeless people. 10 different organizations helped us recruit them across Canada, and we've hired 5 of them to work with us through all the systematic reviews and guideline development as community scholars. And we know that Housing First works. This is going to be very exciting, and it's coming along with a series of recommendations for practitioners. Now, I would say it's not as fast as cardioversion in terms of making a patient better, but I'd say it's more like thrombolytics, because it can provide a long life for people that are either suffering on the street and real opportunities for them. So we can't just warehouse and forget marginalized patients. They need support, and they need to be linked to the health system.
I am an advocate in the community. I speak from a perspective of lived experience. I work for a nonprofit organization where I've went through a leadership program, but now I also support people through their barriers that I faced not too long ago. I fell into poverty, fleeing abuse. I had to leave my job, my family, my friends behind. I didn't know about resources. I didn't know about things that could help me pull myself out of poverty. And we always say that there's a safety net, but I found it more to be a web. I was stuck. I was faced with barriers and barriers. But during the survival mode, I didn't take my health into consideration. I was just wanting to get back on my feet. I did receive good care, but I didn't have a steady doctor. So I would go to drop-in clinics, different, resources, emergency rooms, and I found it very challenging. I would change some things, but I don't regret it because it's led me to the wonderful work I'm doing today. Oh. We work with resident doctors, resident students, doctors, and doctors in the community, and we have a group, and we talk about our experiences around treating poverty as a symptom. How you heard discussed how we are dying quicker, we are exposed to different diseases. And how to ask questions, how to provide the resources to see what people need.